Good afternoon, everyone. This is Christine at Health Current. Hope you're having a wonderful day today. We are just about ready to get our webinar underway. This is the Objective 2 Electronic Prescribing, Objective 3 Clinical Decision Support, and Objective 4 Computerized Provider Order Entry. The presentation today is provided through a shared commitment between Access, ADHS, Health Current, and Myers and Stouffer to increase participation in the Medicaid Promoting Interoperability, or PI program. Just a few logistic reminders. Today's webinar will be recorded and posted to the Health Current and Access websites. We encourage you to use the chat box for questions or comments. Please include your name, practice organization, and do not include any confidential information such as patient health information, PHI. Again, we will be muting all lines, and I would ask Connie, if she is on the line, to please introduce our speaker.
Thank you, Christine. Priscilla Clark, as Senior Accountant with Myers and Stouffer, a certified public accounting firm specializing in federal and state Medicare and Medicaid programs, is our presenter today. She is an excellent presenter. I've heard her many times, so we're very lucky today. So Priscilla, proceed with your presentation, please.
Thank you, Connie. So we will be discussing 3 different objectives during today's webinar: electronic prescribing, clinical decision support, and computerized provider order entry. Okay, so these are going to be our learning objectives for today. The first one is to understand the Medicaid Promoting Interoperability Program requirements for Objective 2, electronic prescribing, Objective 3, clinical decision support, which will be referred to as CDS throughout this presentation. And then Objective 4, computerized provider order entry, which will be referred to as CPOE throughout this presentation. The second objective is to understand the differences in those objectives between program year 2018 and program year 2019. The third objective is to learn about the documentation requirements for those objectives. So the first objective is Objective 2, electronic prescribing. The objective is to generate and transmit permissible prescriptions electronically. The measure is that more than 60% of all permissible prescriptions written by the eligible professional are queried for a drug formulary and transmitted electronically using a certified electronic health record technology. Prescription definition is the authorization by an EP to a pharmacist to dispense a drug that the pharmacist would not dispense to the patient without such authorization. Authorizations for items such as durable medical equipment or other items and services that may require EP authorization before the patient could receive them are not included in the definition of prescription. These are excluded from the numerator and the denominator of the measure. Over-the-counter, or OTC, medications are not included in the definition of prescription. Permissible prescriptions may include or not include controlled substances based on EP selection where creation of electronic prescription for the medication is feasible using CERT and allowable by state and local law. An exclusion is when CMS allows some exceptions for EPs to omit from reporting on a measure. Exclusions vary depending on the measure. An EP must still submit documentation to support qualifying for the applicable exclusion. EPs must use CERT as the sole means of creating the prescription. An EP must use standards adopted for CERT when transmitting to an external pharmacy independent of his or her organization. The generation and transmission of prescriptions occurs concurrently if the prescriber and dispenser are the same person or accessing the same record in an integrated EHR to create an order in a system that is electronically transmitted to an internal pharmacy. An EP should include electronic transmissions to providers both within and outside his or her organization in the numerator and denominator for the measure of this objective. Prescriptions transmitted electronically within an organization, otherwise known as the same legal entity, do not need to use the National Council for Prescription Drug Program standards. However, an EP's EHR must meet all applicable certification criteria and be certified as having the capability of meeting the external transmission requirements of 45 CFR. The EHR that is used to transmit prescriptions within the organization would need to be CERT. EPs can use intermediary networks that convert information from the CERT into a computer-based fax in order to meet this measure, as long as the EP generates an electronic prescription and transmits it electronically using the standards of CERT to the intermediary network. And this results in the prescription being filled without the need for the EP to communicate the prescription in an alternative manner. EPs may simply use the formulary query function available to them in their CERT with no further action required. If a query using their CERT is not possible or shows no result, an EP is not required to conduct any further manual or paper-based action in order to complete the query, and he or she may count the prescription in the numerator. An EP is permitted but not required to limit the measure of this objective to those patients whose records are maintained with CERT. Instances where patients specifically request a paper prescription may not be excluded from the denominator of this measure. The denominator includes all prescriptions written by the EP during the PI reporting period. As electronically prescribing controlled substances is now possible, EPs may choose to include these prescriptions in their permissible prescriptions where feasible and allowable by state and local law. If an EP chooses to include such prescriptions, he or she must do so uniformly across all patients and across all allowable schedules for the duration of the PI reporting period. The state of Arizona recommends including controlled substances when reporting the measure if inclusion would not prohibit the provider from meeting the measure. So what were the changes from modified stage 2 to stage 3? Electronic prescribing. In Program Year 2018, this measure was originally known as Objective 4. In Program Year 2019, it is now considered and called Objective 2. The meaningful use stages did change. In Program Year 2018, it was modified stage 2, and in Program Year 2019, it is stage 3. The threshold in 2018 was greater than 50%. However, CMS did increase that threshold to greater than 60% in Program Year 2019. So exclusions. EP is not required to submit data to meet the measure, and the EP must submit documentation of how he or she met the exclusion. The specific exclusions for Objective 2, electronic prescribing, is first, the number of permissible prescriptions criteria, and the second, pharmacy proximity criteria. So let's look further into what those two exclusions require. The first exclusion, EP may take an exclusion if any of the following apply. The EP writes fewer than 100 permissible prescriptions during the PI reporting period, or does not have a pharmacy within their organization, and there are no pharmacies that accept electronic prescriptions within 10 miles of the EP's practice location at the start of his or her PI reporting period. EPs who are part of an organization that owns or operates its own pharmacy within the 10-mile radius are not eligible for the exclusion, regardless of whether that pharmacy can accept electronic prescriptions from EPs outside of the organization. EPs practicing at multiple locations are eligible for the exclusion if any of their practice locations that are equipped with CERT meet the exclusion criteria. What type of documentation is required when an EP claims an exclusion? So for the first exclusion, which is when the EP writes fewer than 100 permissible prescriptions, there are two different options. The first option is the CERT dashboard shows that the EP wrote fewer than 100 permissible prescriptions during the PI reporting period, or provide supporting documentation other than the CERT dashboard that demonstrates that EP has fewer than 100 permissible prescriptions. The second exclusion, which is no pharmacy within an organization or within 10 miles of EP's practice, there are two things that need to be submitted. First, the documentation showing the closest pharmacy to the practice at the start of the PI reporting period. And the EP must demonstrate how he determined no pharmacy is within 10 miles of the practice. Documentation for Objective 2 electronic prescribing. A CERT-generated dashboard for the selected PI reporting period that shows the following: the provider's name, the numerator, the denominator, and the measure percentage. Keep in mind that in certain situations, a non-cert generated report may be necessary. The use of a non-cert generated report may be permitted upon access, review, and approval. Moving on to Objective 3, Clinical Decision Support. The objective is to implement clinical decision support interventions focused on improving performance on high-priority health conditions. An EP must satisfy both measures for this objective through a combination of meeting the thresholds and exclusions. Objective 3, Measure 1. Measure 1 is to implement 5 CDS interventions related to 4 or more ECQMs at a relevant point in patient care for the entire PI reporting period. Absent 4 electronic ECQMs related to an EP scope of practice or patient population, the CDS interventions must be related to high-priority health conditions. CDS definition is health information technology functionality that builds upon the foundation of an EHR to provide persons involved in care processes with general and person-specific information, intelligently filtered and organized at appropriate times to enhance health and healthcare. While many providers may associate CDS with pop-up alerts, alerts are not the only method of providing support. CDS can be provided in various ways, including, but not limited to, the following: interruptive activities such as pop-up alerts, information displays or links such as an info button, or targeted highlighting of relevant data. There is no definitive or comprehensive list of what constitutes CDS. Certain types of CDS that would meet the means of use definition include support for public health reports and patient safety reporting. A CDS tool can inform a provider that a patient has a reportable condition. It could then provide a template to ensure that the information necessary to complete reporting is captured, and/or provide pre-populated forms needed to make the report. For example, entering adverse drug events, lifestyle factors, environmental and public health issues, social determinants of health, and goals for care. CDS may not necessarily occur at the point of care or may not target the EP. Instead, CDS may be more appropriately directed towards the office staff responsible for populating and submitting report forms. CDS in the form of documentation templates and order sets not only helps EPs remember to complete safety event reports, but it may also help them capture the data they need to do so. In this case, the CDS could be explicit, such as, here is a template for public health or safety reporting. Alternatively, the CDS may simply be incorporated into general templates, perhaps by adding important safety data into high-risk order templates. For example, that could be anticoagulant orders or respirator use. Well-designed CDS encompasses a variety of workflow-optimized information tools, which can be presented to providers, clinical and support staff, patients, and other caregivers at various points in time. These may be included, but are not limited to, the following: computerized alerts and reminders for providers and patients, information displays or links, context-aware knowledge retrieval specifications that provide a standard mechanism to incorporate information from online resources, commonly referred to as info buttons, clinical guidelines, condition-specific order sets, or focused patient data reports and summaries. It can also include documentation templates, diagnostic support, or contextually relevant reference information. These functionalities may be deployed on a variety of platforms. It can be mobile or it can be cloud-based, or there could be other options. EP should implement the CDS intervention at a relevant point in clinical workflows, when the intervention can influence clinical decision-making before diagnostic or treatment action is taken in response to the intervention. The same interventions do not have to be implemented for the entire PI reporting period, as long as the threshold of 5 is maintained for the duration of the PI reporting period. If there are limited ECQMs applicable to an EP scope of practice, The EP should implement CDF interventions that he or she believes will drive improvements in the delivery of care for high priority health conditions relevant to their specialty and patient population. These high priority conditions must be determined prior to the start of the PI reporting period in order to implement the appropriate CDS to allow for improved performance. CDS interventions are not required to be related to the same ECQM that an EP has chosen to report. The CDS intervention should be aimed at prospectively advancing the same clinical goal or guideline promoted by the ECQM. Drug and drug allergy interaction alerts are separate from the 5 CDS interventions and do not count toward the 5 required for Measure 1. And we will discuss drug and drug allergy interaction checks in Measure 2. So what changed from modified stage 2 to stage 3? The meaningful use objective in Program Year 2018 was Objective 2, Measure 1. In Program Year 2019, it is now called Objective 3, Measure 1. And it's not, in Program Year 2018, it was modified stage 2, and in Program Year 2019, it is now stage 3. The clinical decision support exclusions. For an exclusion, the EP is not required to submit data or meet the measure, but the EP must submit documentation of how he or she meets the exclusion. The exclusion for Objective 3, Measure 1, CDS interventions. There are actually no allowable exclusions available. The EP must meet the measure. Documentation for clinical decision support. The following documentation that is submitted should include all 4 of these items. It should include the provider or practice name. The documentation should include the 5 CDS interventions related to 4 or more ECQMs that were enabled. It should be clearly legible, and it should reflect the date the requirement was met during the PI reporting period. Keep in mind for that second item, 5 CDS interventions related to 4 or more ECQMs. Absent 4 ECQMs related to an EP scope of practice or patient population, the CDS intervention must be related to high priority health conditions. An example is screenshots from the CERT or vendor letters to support the 5 CDS rules were enabled. Here is an example of that CDS rule. As you can see, it shows the date and time taken right here. That date should be during the PI reporting period to make sure the 5 CDS rules that you document and submit with your attestation show that date on there, and that date should fall within the PI reporting period. At the top, you can see the provider name was originally there, but that was redacted. And then towards the bottom, it talks about weight, head circumference, body mass index, and that CDS rule relates to the CQM CMS 69. And as you can see, it highlights that high there in the bottom right-hand corner. It's showing that criteria is high for this specific patient. So you're showing why it's kind of important to that patient when they come in that that's one of the CDS rules. So this is just one example, and this is a BMI and weight example. So you should ensure documentation includes the items listed on slide 26 and is dated appropriately. Here's another documentation example. It is a letter from the practice's CERT stating that 5 CDS rules were turned on. Towards the bottom, you can see those bullet points. It identifies the CDS rules that were enabled and cannot be disabled. And so this is a generic letter. You need to make sure that if you do reach out to your vendor to provide this letter, that it has the practice date on it, it has the reporting period date, and identifies that those CDS rules, that there was 5 CDS rules, and just double check to make sure 5 of those CDS rules will relate to at least 4 electronic CQMs. You need to ensure that the documentation includes the items listed on slide 26 and is dated appropriately. Let's move on to Objective 3, Measure 2, drug-drug and drug allergy interaction checks. The measure is to enable and implement the functionality for drug-drug and drug allergy interaction checks for the entire PI reporting period. So what were the changes from modified stage 2 to stage 3? The objective was originally Objective 2, Measure 2 in Program Year 2018. However, in Program Year 2019, it is now called Objective 3, Measure 2. In Program Year 2018, it was modified stage 2, and in Program Year 2019, it is stage 3. Are there any exclusions for this measure? The EP is not required to submit data or meet the measure. The EP must submit documentation of how he or she met the exclusion though. The exclusion for Objective 3, Measure 2, drug-drug and drug allergy interaction checks, is the number of medication orders criteria. The exclusion for drug-drug and drug allergy interaction checks is that an EP may take an exclusion for Measure 2 if the EP writes fewer than 100 medication orders during the PI reporting period. Okay. What type of exclusion documentation is required? There are two different options when an EP writes fewer than 100 permissive prescriptions. The EP can either submit the CERT dashboard, which shows the EP wrote fewer than 100 medication orders during the PI reporting period, or the EP can provide supporting documentation other than the CERT dashboard that demonstrates the EP has fewer than 100 medication orders. Okay, so what type of documentation must an EP submit to meet the drug-drug and drug allergy interaction check? The documentation submitted should include the following, all 4 items. It should include the provider and or practice name. The drug-drug and drug allergy interaction checks were enabled. It should be clearly legible, and it should reflect the date the requirement was met during the PI reporting period. For example, screenshots from the CERT or vendor letters to support drug-drug and drug allergy interaction checks were enabled. Here is an example. As you can see in the top left-hand corner, it's saying that the provider name was up there, but we had to redact the practice name at the top. As you can see, moving down, halfway down, you can see that it talks about medication. It talks about electronic prescribing interaction checking. It talks about the medication and whether there is that interaction. This screenshot supports the provider had drug-drug interactions enabled during the PI reporting period. We want to ensure the documentation includes the items listed on slide 35 and is dated appropriately. For example, the screenshot could include the toolbar on the bottom right of the screen to show the date the screenshot was taken. The date needs to be within the PI reporting period. As you can see, it does not clearly show the date during the PI reporting period for when this drug-drug and drug allergy interaction checks were in it or checked for this specific patient. Here is another example. There's a pop-up in the middle of the screen and that says this patient has medication allergies. So that's another one that's signifying that it was checked and that something did occur and that the patient did have an allergy. You want to make sure that those 4 items from slide 35 is in the screenshot that you submit. The provider practice name, the drug-drug and drug allergy interactions were checked, that it's clearly legible, that we can read it to make sure it says drug-drug and drug allergy interaction checks were enabled, and that is dated inside the PI reporting period. Moving on to Objective 4, Computerized Provider Order Entry. Objective is to use CPOE for medication, laboratory, and diagnostic imaging orders directly entered by any licensed healthcare professional, credentialed medical assistant, or a medical staff member credentialed to and performing the equivalent duties of a credentialed medical assistant. You can enter orders into the medical record per state, local, and professional guidelines. An EP, through a combination of meeting the thresholds and exclusions, or both, must satisfy all 3 measures for this objective. Measure 1, more than 60% of medication orders created by the EP during the PI reporting period are recorded using CPOE. Measure 2, more than 60% of laboratory orders created by the EP during the PI reporting period are recorded using CPOE. Measure 3, more than 60% of diagnostic imaging orders created by the EP during the PI reporting period are recorded using CPOE. As you can see, all 3 measures require a 60% threshold. So what is CPOE? It's a provider's use of computer assistance to directly enter medical orders. For example, medications, consultations with other providers, laboratory services, imaging studies, and other auxiliary services from a computer or mobile device. CPOE is the entry of the order into the patient's EHR that uses a specific function of CERT. CPOE does not otherwise specify how the order is filled or otherwise carried out. Diagnostic imaging. It includes other imaging tests such as ultrasound, magnetic resonance, and computed tomography in addition to a traditional radiology. Laboratory order is an order for any service provided by a laboratory that could not be provided by non-laboratory. Laboratory, a facility for the biological, microbiological, serological, chemical, immunohematological, hematological, biophysical, cytological, pathological, or other examination of the human body for the purpose of providing information for the diagnosis, prevention, or treatment of any disease or impairment of, or the assessment of the health of human beings. These examinations also include procedures to determine, measure, or otherwise describe the presence or absence of various substances or organisms in the body. Facilities only collecting or preparing specimens, or both, or only serving as a mailing service and not performing testing are not considered laboratories. A radiology order is an order for any imaging service that uses electronic product radiation. The EP can include orders for other types of imaging services that do not rely on electronic product radiation in this definition, as long as the policy is consistent across all patients and for the entire PI reporting period. EPs are permitted but not required to limit the measure of this objective to those patients whose records are maintained using CERT. To count in the numerator, the CPOE function must be used to create the first record of the order that becomes part of the patient's medical record and before any action can be taken on the order. In some situations, it may be impossible or inadvisable to wait to initiate an intervention until a record of the order has been created. For example, situations where an intervention is identified and immediately initiated by the EP, or initiated immediately after a verbal order by the ordering EP to a licensed healthcare professional under his or her direct supervision. In these situations, as long as the first record of that order, as it becomes part of the patient's medical record, is entered by a licensed healthcare professional, certified medical assistant, or other appropriately credentialed staff member using CPOE, it would count in the numerator. Orders need to be directly entered by any licensed healthcare professional, credentialed medical assistant, or a medical staff member credentialed to and performing the equivalent duties of a credentialed medical assistant. Any licensed healthcare professional and clinical staff credentialed to and with the duties equivalent of a medical assistant, or is appropriately credentialed and performs assistive services similar to a medical assistant, but carries a more specific title due to either specialization of their duties or to the specialty of the medical professional they assist, can enter orders into the medical record for purposes of including the order in the numerator if they can originate the order per state, local, and professional guidelines. It is up to the EP to determine the proper credentialing, training, and duties of the medical staff, entering the orders as long as they fit within the guidelines prescribed. Credentialing for a medical assistant must come from an organization other than the organization employing the medical assistant. Orders involving telehealth or remote communication, such as phone orders, may be included in the numerator as long as the order entry otherwise meets the requirements of the measures. EPs may exclude orders that are predetermined for a given set of patient characteristics or for a given procedure, also known as protocol or standing orders. From the calculation of CPOE numerators and denominators, this does not require EPs to exclude this category of orders from the numerator and denominator. So what changed from modified stage 2 to stage 3 for CPOE? In Prgm 2018, it was called Objective 3, and now in Prgm 2019, it is called Objective 4. The means of use stages did change. In Prgm 2018, it was modified stage 2, and now EPs are required to attest to stage 3 in Prgm 2019. Measure 1 thresholds remain the same. In 2018 and 2019 is at 60% threshold. For measure 2, the threshold did change. In Prgm 2018, it was originally a 30% threshold, more than 30%. However, in Prgm 2019, CMS did increase that threshold to more than 60%. For measure 3, the threshold increased as well. In Prgm 2018, it was more than 30%. and in Prgm 2019, it was increased to more than 60%. An additional change to Measure 3 was that in 2018, it was only radiology orders were included in Measure 3 for the numerator and denominator. Now in Prgm 2019, it is all diagnostic imaging orders. Exclusions. The EP is not required to submit data or meet the measure, but they meet the exclusion. But the EP must submit documentation for how he or she met the exclusion. The exclusion for Objective 4, computerized provider order entry. The first exclusion is the number of medication orders criteria. The second is the number of laboratory orders criteria. And the third is the number of diagnostic imaging orders criteria. An EP may take an exclusion for the appropriate measure if, for Measure 1, the exclusion is that an EP writes fewer than 100 medication orders during the PI reporting period. For Measure 2, an EP who writes fewer than 100 laboratory orders during the PI reporting period may take an exclusion. For Measure 3, an EP who writes fewer than 100 diagnostic imaging orders during the PI reporting period may take the exclusion. So what type of documentation is required for the exclusion? So any EP who writes fewer than 100 orders for the applicable measure needs to either submit one of the following: the CERT dashboard that shows the EP wrote fewer than 100 orders for the applicable measure during the PI reporting period, or provide supporting documentation other than the CERT dashboard that demonstrates the EP has fewer than 100 orders for the applicable measure. A CERT-generated dashboard for the selected PI reporting period should be submitted to meet the CPOE measures. And it should show the following 4 items: the provider's name, the numerator, the denominator, and the measure percentage. Keep in mind that in certain situations, a non-CERT generated report may be necessary. The use of the non-CERT generated report may be permitted upon access, review, and approval. So let's look at audit findings when it comes to these 3 objectives that we've discussed during today's presentation. So what happens during an audit? All providers that receive a Medicaid PI incentive payment could potentially be selected by Access for post-payment audit. If selected, Access post-payment analysts will conduct a thorough review of the documentation attached to EP's attestation in EPIP to determine if it meets the program requirements. Access may have follow-up questions or make additional documentation requests. So what are some common audit findings? The first is failure to provide sufficient documentation for any of the 3 objectives: electronic prescribing, clinical decision support, and computerized provider order entry objectives. The second is the CERT dashboard does not show the PI reporting period or EP name. The CERT dashboard needs to show both of those items. Another common failure is to maintain proper documentation, and the practice no longer has access to the CERT. So make sure to gather that documentation when you're first attesting for the program. Another item is supporting documentation does not have the appropriate dates. Make sure screenshots, CERT dashboard, all have the appropriate dates that are needed to meet the measures. The last is including data for the entire practice in the reported CERT report rather than data for the individual EP. Keep in mind for all percentage-based measures, the CERT dashboard and that percentage that the EP needs should be respective of that individual EP that is attesting to the program. You cannot include the entire practice numerator and denominator to meet the threshold. Here are some resources that we have used to put together all of this information, and that you can click on these different links to do even further research. If you have additional questions about where we pulled that from, it's all going to be in those different links. You can also, which we will discuss towards the end of this presentation, towards the bottom you can see Access Prgm 2019. There's 3 different FAQs, 1 for each objective. So depending on which one you have the most questions about, you can go to each of those FAQs and look at some of the questions that we've put together that we believe some providers have when they're testing for the program. Today's presentation and its FAQs should be available within the next week or 2 on the Health Current and the Access website. Here's some contact information from Access and Health Current. If you do have any additional questions after this presentation is over, feel free to reach out to them by email or by phone to ask any questions you may have. And we'll be taking questions at this time. So Christine and Connie.
Christine, do we have any questions in the chat box?
We currently do not have any questions in the chat box. To give folks a few minutes to type those in, and we'll be happy to answer them.
Perfect. Thank you, Christine. And what I will do is I will bring up the FAQs for the 3 different presentations that we have. So we'll look at electronic prescribing first. Christine, please interrupt me if anyone posts any comments in the chat box, and I'll be happy to answer those questions.
Absolutely. Thank you, Priscilla.
And so here's the FAQ just for specific to electronic prescribing. And so it goes through what is a prescription, what are permissible prescriptions, must the EP use the cert when creating a prescription to count towards meeting the measure? Question 3. And the answer is yes. The EP must use the cert as the sole means of creating a prescription for it to be considered electronic and included in the numerator of the electronic prescribing measure. All prescriptions, regardless of how they are created, should be included in the denominator for the measure. Question 4 is what standards must be used to transmit electronic prescriptions to external pharmacies? The answer is that for the prescription to be counted towards meeting the measure, an EP must use standards adopted for CERT when transmitting to an external pharmacy independent of his or her organization. Okay, question 5, does an EP transmitting electronic prescriptions within an organization, the same legal entity, have to use the National Council for Prescription Drug Program standards? And the answer is no. If the EP is transmitting electronic prescriptions within an organization, the same legal entity, the EP does not have to use the National Council for Prescription Drug Program standards. However, an EP's EHR must meet all the applicable certification criteria and be certified as having the capability of meeting the external transmission requirements of 45 CFR. We're going to go down to a few other questions, trying to highlight the most important ones. If a patient, question 9, if a patient requests a paper prescription, is the EP able to exclude the prescription from the denominator? No, when a patient requests a paper prescription, the EP may not exclude the prescription from the denominator. The denominator includes all prescriptions written by the EP during the PI reporting period. Question 10, is an EP allowed to include electronic prescribed controlled substance to the measure? Yes, EPs may choose to exclude electronic prescribed controlled substances in their permissible prescriptions where feasible and allowable by state and local law. If an EP chooses to include such prescriptions, he or she must do so uniformly across all patients and across all allowable schedules for the duration of the PI reporting period. Keep in mind that the state of Arizona recommends including controlled substances when reporting the measure if inclusion would not prohibit the provider from meeting the measure. Okay, so what should the documentation for question 12 show to reflect the EP needs objected to? The EP should submit a CERT-generated dashboard for the selected PI reporting period that shows the following. It's the provider's name, and make sure that's not the practice name. The numerator and denominator and the measure percentage that is required should be reflective of that specific provider who is attesting to the program. In certain situations, a non-CERT generated report may be necessary. The use of non-CERT generated reports may be permitted upon access, review, and approval. Okay, so let's talk about a few questions about the exclusions for this objective. Question 13, what exclusions are available to an EP for objective 2? An EP may take an exclusion if any of the following apply. The number of permissible prescription exclusion, which is when an EP writes fewer than 100 permissible prescriptions during the PI reporting period. The second type of exclusion an EP can claim is the pharmacy proximity exclusion. It's when an EP does not have a pharmacy within their organization and there are no pharmacies that accept electronic prescriptions within 10 miles of the EP's practice location at the start of his or her PI reporting period. Question 14, does the EP meet the exclusion if the EP is part of an organization that operates its own pharmacy within the 10-mile radius but does not accept electronic prescriptions from EPs outside of the organization? The answer is no. EPs who are part of an organization that owns or operates its own pharmacy within a 10-mile radius are not eligible for the exclusion, regardless of whether that pharmacy can accept electronic prescriptions from EPs outside of the organization. Question 15, is an EP eligible for the pharmacy proximity exclusion if the EP practices at multiple locations and one of the locations equipped with CERT meets the pharmacy proximity criteria discussed in question 13? Yes, EPs practicing at multiple locations are eligible for the exclusion if any of their practice locations that are equipped with CERT meet the exclusion criteria. So, for example, if an EP works at 3 locations and they don't meet the exclusion at the first 2. So practice A and practice B do not meet the exclusion because they're the pharmacy within 10 miles of their practice. But pharmacy C does not have a pharmacy within 10 miles of that practice that accepts electronic prescriptions. That means the EP meets the exclusion at pharmacy C, and therefore overall for this program would meet the exclusion for that measure. Okay, question 16, what should the documentation show to reflect that the EP meets the number of permissible prescription exclusion discussed in question 13? The following type of documentation would be sufficient to support that the EP meets the number of permissible prescriptions exclusion. There are 2 different options an EP can use. They can first submit a CERT dashboard that shows the EP wrote fewer than 100 permissible prescriptions during the PI reporting period. Or the second option is to provide supporting documentation other than the CERT dashboard that demonstrates the EP is fewer than 100 permissible prescriptions. Question 17, what should a documentation show to reflect the EP meets the pharmacy proximity exclusion discussed in question 13? The EP should provide documentation supporting the following. It should show the closest pharmacy to a practice at the start of the PI reporting period, and the EP must demonstrate how he or she determined no pharmacy is within 10 miles of the practice. So examples of that could be screenshots of maps, if you go to Google Maps and try to see where the closest pharmacy is and mapping that out, things along those lines, and just explain the process that you went through to determine there were no pharmacies within 10 miles of the practice. Okay, I'm going to bring up the CDS. FAQ, if you do have any questions, we would love to answer those for you if you put them in the chat box.
Thank you again, Priscilla. We have not received any questions come through yet, but folks, if you want to go ahead and type those in, we'll be able to answer those before the conclusion of today's presentation. Thank you.
Thank you, Christine. So I have the clinical decision support FAQ up. And so I'm going to scroll through the first few because I want to get to more of the questions that have more substantial information in there. So what methods, question 3, what methods are sufficient for supporting CDS intervention? The answer is that while many providers may associate CDS with pop-up alerts, alerts are not the only method of providing support. CDS can be provided in various ways, including but not limited to interruptive activities such as pop-up alerts, information displays or links such as the info button, or targeted highlighting of relevant data. There is no definitive or comprehensive list of what can constitute CDS. Certain types of CDS that would meet the means of use definition include support for public health reports or and patient safety reporting to either or of those items. Question 14, when should an EP implement the CDS intervention? The answer is that the 5 CDS interventions should be enabled prior to or during the PI reporting period. The same interventions do not have to be implemented for the entire PI reporting period as long as the threshold of 5 is maintained for the duration of the PI reporting period. EP should implement the CDS intervention at a relevant point in clinical workflows when the intervention can influence clinical decision-making before diagnostic or treatment action is taken in response to intervention. Keep in mind that the documentation to show that your CDS alerts were enabled need to be dated during that PI reporting period. So it shows that at some point in that 90-day PI reporting period, you did have those CDS rules turned on. You can turn them on prior to the reporting period, but we need to see that they were turned on during the PI reporting period. Question 5, do all CDS interventions have to be related to ECQM? No. Not all CDS interventions have to be related to ECQM. However, to qualify for this measure, an EP must implement 5 CDS interventions related to 4 or more ECQMs at a relevant point in patient care for the entire PI reporting period. Question 6, do the CDS interventions have to be related to ECQMs that an EP has chosen to report on? No. CDS interventions are not required to be related to the same ECQMs that an EP has chosen to report. The CDS intervention should be aimed at prospectively advancing the same clinical goal or guideline promoted by the ECQM. Question 7. So what if there are not 4 more ECQMs applicable to an EP practice? And the answer is that if there are limited ECQMs applicable to an EP scope of practice, the EP should implement CDS interventions that he or she believes would drive improvements in the delivery of care for high priority health conditions relevant to their specialty and patient population. These high priority conditions must be determined prior to the start of the PI reporting period in order to implement the appropriate CDS to allow for improved performance. So just make sure you're keeping track of that. If you think there's a concern that you would fall into that scenario of not having 4 or more ECQMs applicable to the EP scope of practice, make sure you're looking at that ahead of time before the PI reporting period to make sure the appropriate CDS rules are turned on. Question 8, is an EP able to count drug-drug and drug-allergy interactions as one of the 5 CDS interventions? The answer is no. Drug-drug and drug-allergy interactions are separate from the 5 CDS interventions and do not count towards the 5 required CDS interventions for Measure 1. We'll skip question 9. Question 10, are there any available exclusions for Objective 3, Measure 1? And the answer is no, there are no allowable exclusions available for Objective 3, Measure 1. So the EP is required to turn on and submit supporting documentation that 5 CDS rules were turned on during the PI reporting period. Question 11, what should the documentation show to reflect that CDS rules for Objective 3, Measure 1 were enabled during the PI reporting period? And the answer is the documentation should include 4 things. It should first include the provider and or practice names. We need to tie that supporting documentation to the EP or the practice. It needs to have 5 CDS rules related to 4 more ECQMs that weren't enabled. The documentation needs to be clearly legible, and it needs to reflect the date the requirement was met during the PI reporting period. And because this measure has so much in it, because there's 5 CDS rules, you may have to provide multiple screenshots for these CDS rules. Keep in mind that we did provide an example of one of the CDS rules in the presentation today. So if you do have questions about that, please feel free to ask those now or even down the road. You can email or call Health Current or Access to ask those questions. An example would be a screenshot from the CERT showing the 5 CDS rules were enabled during the PI reporting period. When taking screenshots, make sure to capture the data on your computer screen, usually located in the bottom right-hand corner, especially when if you're taking those screenshots during that PI reporting period. If you're showing that alert popped up on that date you took the screenshot. So make sure you're including the bottom right-hand corner where the date is supposed to be showing for that day. Question 12, does an EP have to enable and implement the functionality for drug-drug and drug-allergy interaction checks to meet the requirements for Objective 3, Measure 2? The answer is yes. An EP must enable and implement the functionality for drug-drug and drug-allergy interaction checks to meet the requirements. We'll skip a few. As you recall for question 14, it talks about what exclusions are available to an EP for Objective 3, Measure 2. And the answer is an EP may take an exclusion if the EP writes fewer than 100 medication orders during the PI reporting period. What should the documentation show to reflect that drug-drug and drug-allergy interaction checks were enabled during the PI reporting period? This is question 16. The documentation should include the following. It should include the provider and or practice name so we can tie it to the provider or the practice that's coming from their cert. Should include the drug-drug and drug-allergy interaction checks being enabled. It should be clearly legible, and it should reflect the date the requirement was met during the PI reporting period. Again, this is similar to CDS, is that an example could be a screenshot from the cert showing that drug-drug and drug-allergy interaction checks were enabled during the PI reporting period. And keep in mind when taking screenshots to capture the data on your computer, the date on your computer screen, which is usually located in the bottom right-hand corner. Those are the only questions we've prepared for the FAQ for CDS. I will move over to the CPOE. Christine, do we have any questions?
We have not currently received any questions in the chat box yet.
Okay, thank you. Y'all keep in mind, there's only a few minutes left for this presentation, so I'll quickly go over the CPOE FAQ. But if you have any questions, please feel free to put those in the chat box, and then we can answer those before the end of today's presentation. Okay, we're going to skip the first few questions because it's kind of going over the definitions that were covered during the presentation. So question 7, is an EP required to limit the measure of objective 4 to those patients whose records are maintained with CERT? The answer is no. An EP is permitted but not required to limit the measure of this objective to those patients whose records are maintained using CERT. Question 8, would a patient be included in the measure if a patient is seen twice during the PI reporting period and the CPOE function was only used on the second visit but not the first visit? The answer is no. For a patient to count in the numerators, the CPOE function must be used to create the first record of the order that becomes part of the patient's medical record, and before any action can be taken on the order. An exception is in some situations, it may be impossible or inadvisable to wait to initiate intervention until a record of the order has been created. For example, situations where an intervention is identified and immediately initiated by the EP, or initiated immediately after a verbal order by the ordering EP to a licensed healthcare professional under his or her direct supervision. In these situations, as long as the first record of that order, as it becomes part of the patient's medical record, is entered by a licensed healthcare professional, a certified medical assistant, or other appropriately credentialed staff member using CPOE, it would count in the numerators. Please keep in mind that this answer was specifically talking about the numerator, so that patient would still be counted in the denominator. Question 9, is any person able to enter the orders into the CERT for it to count in the numerators? The answer is no orders need to be directly entered by any licensed healthcare professional, credentialed medical assistant, or a medical staff member credentialed to and performing the equivalent duties of a credentialed medical assistant. Any licensed healthcare professional and clinical staff credentialed to and with the duties equivalent of a medical assistant or is appropriately credentialed and performs assistive services similar to a medical assistant, but carries a more specific title due to either specialization of their duties or to the specialty of the medical professional they assist. They can enter orders into the medical record for purposes of including the order in the numerators if they can originate the order per state, local, and professional guidelines. It is up to the EP to determine the proper credentialing, training, and duties of the medical staff entering the orders, as long as they fit within the guidelines prescribed. Credentialing for a medical assistant must come from an organization other than the organization employing the medical assistant. I think we have time for about 2, maybe 3 more questions. We'll go through. Question 10 is, would orders involving telehealth or remote communication, such as a phone order, be included in the numerators? The answer is yes. Orders involving telehealth or remote communication, such as phone orders, may be included in the numerators as long as the order entry otherwise meets the requirements of the measure.
Priscilla, we did receive a question. The question is, if a provider meets a measure but also qualifies for an exclusion, should the provider report the measure or take the exclusion? And the example would be a provider e-prescribes 49 out of 50 scripts.
That is a great question. And for the purposes of this program, submitting either attesting to meeting that minimum threshold or the exclusion would count and allow the provider to meet the requirements for that measure. However, because this program is focused on helping providers provide better care, the EP could most likely enter in and try to meet the threshold.
Thank you, Priscilla.
But, no problem. And that is something that certain providers can fall into. But for cases of specifically for the CPOE, just to point out, the exclusion for this measure particularly is that they attest to less than 100. So they could fall under where they have 40, as you said, 49 over 50, and they could meet either one. So we're not checking for this program to sell any specific person. It's more to say, do you meet the exclusion, do you meet the measure, and they're able to meet the program requirements. Okay, we do have a few more minutes. If there's any other questions, we've got 2 minutes left of the presentation. Feel free to put those questions in the chat box and we can answer them. If any of y'all have questions after this presentation is over, please feel free to reach out to us. I'll pull up the email so y'all can see that. There's an email for access for the PI program, and there's also an email for Health Current. So you can reach out to either of those emails to ask any questions that you have or call them via the phone numbers listed.
Wonderful. Thank you so much, Priscilla. I'm not seeing any additional questions come through the chat box at this time. But again, you can submit your questions directly to Access using the EHR incentive payments at azaccess.gov. And the telephone number is also provided on the screen, 602-417-4333. Or you can contact Health Current for educational and assistance support at ehr@healthcurrent.org or dial direct at 602-688-7210. And I believe that brings us right to the 1 o'clock hour. I am not seeing any additional questions come through the chat, but I would like to thank you, Priscilla, for sharing the information about Objective 2, electronic prescribing, Objective 3, clinical decision support, and Objective 4, computerized provider order entry for the Medicaid Promoting Interoperability or PI program. A copy of today's presentation will be sent out to all participants, as well as the recording and the presentation posted to both the Access and Health Current websites. Connie, are you still with us on the line?
I am, Christine. Thank you very much.
Okay. Do you have any closing comments as well?
I do not, other than to thank Access for supporting this today, and also a big thank you goes out to Priscilla for facilitating the webinar. Thank you so much.
Thank you, everyone.
Everyone have a great day.
Thank you. You do the same. Thanks, everybody. Have a great day. Stay safe.